Hello, everyone. My name is Alon Altman. I am a professor of obstetrics, gynecology, reproductive sciences, and a gynecologic oncologist at the University of Manitoba, at the Rady Faculty of Health Sciences, and at Cancer Care Manitoba. It's my pleasure today to be presenting PARP inhibitors for epithelial ovarian cancer, the selection and use in first-line maintenance therapy, and this is a summary of the article that was put out by the group of Canadian oncologists as a consensus statement. My disclosures are as follows. I've received speaker fees, advisory boards, and have been have received several research grants as either principal investigator and co-investigator from the studies listed period. The slide presentation and manuscript was supported with funding from AstraZeneca and was from Impact Medicom. So we're going to start quickly talking about the incidence and prognosis for epithelial ovarian cancers. As I'm sure many of you know, they represent 90% of all ovarian cancers, and the vast majority present in advanced stage disease, so stage 3 and 4. The 5-year survival rate for late stage disease is approximately 30%, depending on the study that you read, and 80% of advanced high-grade ovarian cancers do recur after surgery and response to platinum therapy. The role of PARP inhibitors for maintenance is to decrease recurrence rates as well as prolong remission time, ultimately leading to improved progression-free survival and hopefully improved overall survival. PARP inhibitors work on the homologous recombination repair deficiency pathway through single-stranded DNA breaks. And we know that 50% of epithelial ovarian cancer have a homologous recombination repair deficiency, or HRD. HRD results from alterations in the genes involved in homologous recombination, and an example of those genes include BRCA1 and 2. Patients that do have HRD, either germline or somatic with BRCA1 mutations, BRCA1 or 2 mutations, derive greatest benefit from PARP inhibitors. To understand the mechanism, you can see here in our graphic, PARP inhibitors PARPs normally repair single-strand DNA breaks. When then this is repaired, the cell is able to survive and continue replicating. PARP inhibitors work by blocking the PARP enzyme. Those single-strand DNA breaks are then converted to double-strand DNA breaks. If the cell itself is able to repair homologous recombination, so they have homologous recombination repair ability, or they're HR proficient, the double-strand break is repaired and the cell can continue surviving and proliferate. If, however, they are deficient in this ability, the double-strand break is not repaired and the cell undergoes apoptosis and dies. And this is the basis for how PARP inhibitors work for ovarian cancers. Currently, in Canada, there's 2 PARP inhibitors that are available on the market for first-line maintenance therapy. Olaparib, which is approved for patients with complete or partial response with a platinum-based therapy who have a BRCA1 or 2 mutation, and niraparib in patients that have a complete or partial response to platinum-based therapy, regardless of BRCA1 or 2 mutation status. Without a direct comparison, PARP inhibitors must be selected based on the individual in front of you, considering patient factors, complications, tumor factors, toxicity, and patient wishes after informed consent period. Please note that in this study, in this presentation, we're only going to be talking about first-line maintenance therapy and not addressing second-line maintenance. So a group of gyne-oncologists and medical oncologists that treat gyne cancers was compiled. we created a consensus statement that was published in Current Oncology this year in 2022. We represent centers from across the country and reviewed the use of PARP inhibition maintenance for high-grade epithelial ovarian cancer. The consensus statement reflects evidence from the literature and experiences from the authors, and we discussed standard of care for PARP maintenance, current gaps in knowledge, and access to testing and treatment, and what this group recommends and identifies the current difficulties. So this is a list of the consensus statement categories, and we'll go through each one independently. And we're going to start with the consensus statement, the genetic testing to inform PARP inhibitor maintenance strategies. So the group consensus on genetic testing came down to that all patients with a high-grade epithelial ovarian cancer should have a BRCA1 and 2 mutation testing for two reasons. The first reason is to inform hereditary cancer predisposition, to aid the family in further BRCA testing, and to inform both the patient, their family, and relatives of that information. That critical information can then lead to other family members being tested, but also prophylactic surgery and prophylaxis for prevention. The second part was to guide first-line PARP maintenance or PARP inhibitor maintenance therapy in advanced stage cases. Tumor HRD status is a predictive biomarker of treatment for PARP inhibitors, and the consensus statement was that the testing should be publicly funded. And finally, assessment of mutations with HR recombination genes other than BRCA1 should not be used as a substitute for HRD testing, in that doing mutation status for other known HRR genes certainly can be important, but is not a substitute for a proven HRD test. So quickly going through some of our target testing, BRCA1 and 2 mutations make up, in the germline setting, make up 5 to 15% of epithelial ovarian cancer and make up approximately 20% of high-grade serous cancers. In the somatic setting, in epithelial ovarian cancers, they make up 7% of the incidence. HRD in epithelial ovarian cancer can make up to 50% of the cancers. We know that germline testing for BRCA mutations increases the risk of epithelial ovarian cancers and breast cancers, and the lifetime risk of epithelial ovarian cancer with a BRCA1 mutation is in the realm of 40 to 60%, and with BRCA2 mutation in the realm of 11 to 27%. You can see that in the HRD testing category, other mutations in the homologous recombination repair pathways that have been linked to increased risk of epithelial ovarian cancer include RAD51C, RAD51D, BRIP1, as well as others. But as noted before, we don't recommend testing these genes as a substitute for HRD testing. And finally, for the prognosis with BRCA mutated patients, they have a better 5-year overall survival rate compared to wild type, and the best prognosis seems to be reported for BRCA2 mutations. And we know that HRD identified mutations do have improved progression-free survival and overall survival compared to the HRP or proficient group. So this is really important for prognosticating as well as treatment strategies and informing the patients and their families. I'm sure many of you are aware of some of the trials that have been done, but we'll go through these quite quickly. SOLO-1 was a study looking at first-line maintenance for olaparib versus placebo. It looked at the BRCA mutated cohort and showed an improvement in progression-free survival. PRIMA compared niraparib to placebo, and you can see it was broken down by intention to treat, the HRD category, the BRCA mutated category, the HRD with BRCA wild type category, and the HR proficient category. In all the categories, progression-free survival was improved with niraparib. They were all statistically significant, but as you can see, the highest improvement was in the HR proficient, the HR deficient, HRD, and the BRCA categories. The smallest progression-free benefit was in the HRP category. Paola 1 looked at combining a PARP inhibitor with bevacizumab. Patients were randomized to olaparib with bevacizumab or placebo with bevacizumab as maintenance. And again, they had similar categories to PRIMA, which included intention to treat, HRD, BRCA mutated, HRD, BRCA wild type, and HRP. There was a progression-free survival benefit in the groups that, so intention to treat, HRD, the BRCA mutated group, and the HRD, BRCA wild type. There was not a benefit in the HRP group in this study. Finally, VELIA was carbotaxol plus veliparib, and then maintenance or placebo versus carbotaxol placebo followed by placebo maintenance. Veliparib is not available in Canada at this time, but again, you can see from the data the trend was showing a significant benefit to HRD and BRCA mutated patients in progression-free survival benefit. So ASCO, ESMO, and GOC all recommend patients with high-grade epithelial ovarian cancer be tested for BRCA1 mutations. As mentioned previously, this germline testing can trigger familial testing, prevention strategies, prophylactic surgeries, and screening. Germline testing alone misses approximately 7% of patients that have somatic mutations, and tumor testing alone misses approximately 5% of patients that have germline mutations. Sequencing of germline and somatic testing should be prioritized based on timeliness and resources, and the panel did recommend that both germline and somatic testing for BRCA1 be performed, and reflex tumor testing is encouraged. Certainly, this is available in many provinces with different sequence of events. Some do both testing together, some do germline, some do reflex tumor testing, and then germline testing. And we encourage you to connect with your local cancer society, your local cancer community, and your gynae oncologists and medical oncologists to review what's done in your province. The consensus also felt that access to a validated HRD test is currently limited in Canada, and we felt that HRD testing can inform the magnitude of benefit for maintenance niraparib, and gives patients more information to be able to make informed treatment decisions. Of course, the issue with HRD testing currently in the Canadian system is the cost, but the group did feel that even with this, we recommend that all patients with advanced high-grade epithelial ovarian cancer should have access to HRD testing. Now, there were several caveats that the group had wanted to point out to HRD testing. The predictive value of HRD testing is only validated in the first-line therapy with platinum response and platinum-sensitive disease. HRD may change over time with multiple therapies, and therefore testing may not be meaningful in the platinum-resistant cohort. The Myriad test is a commercially performed HRD test. It was the test that was performed in the PRIMA trial, and it assesses BRCA1 and 2 mutations and then calculates genomic instability based on loss of heterozygosity, telomeric imbalance and instability, and large-scale transitions. Testing has its limitations because even if you identify patients that are HRD, there is some benefit to PARP inhibition in the HRP population. So the group felt that even though we recommend HRD testing be done, HRD status should not be the only guiding factor for decision, and maintenance after first-line platinum-based chemotherapy should be considered and discussed with the patient in a clinical setting. Obviously, other homologous recombination repair genes exist. Up to 9% of epithelial ovarian cancers have a mutation in an HARR gene associated with improved survival and response to platinum chemotherapy. There is a small retrospective analysis of trials with recurrent high-grade cancers suggesting that HRR genes may have a benefit in predicting responses to PARP inhibitors. However, no large studies have been performed, and there's no data suggesting that HRR gene mutations can be used as a substitute for HRD testing. So the group consensus was that mutation status of other HRR genes is not sufficient to inform PARP inhibitor treatment and should not take over instead of tested and approved HRD testing. The next consensus statement that we're going to review is selection of PARP inhibitors as first-line maintenance therapy in advanced ovarian cancers. So based on selection, the consensus statements include several sections. We felt that all BRCA1 and 2 mutated patients with advanced epithelial ovarian cancer should receive a maintenance therapy with a PARP inhibitor after platinum-based chemotherapy. The choice of which PARP inhibitor is influenced by several factors, including toxicity, patient preference, and availability. And as a reminder, the two PARP inhibitors that are currently approved in Canada are olaparib and niraparib. Patients with advanced ovarian cancer who are BRCA wild type but have responded to a platinum-based chemotherapy should be considered for maintenance therapy with niraparib. And niraparib, since this is the PARP inhibitor that's indicated and approved in this setting. There is evidence to support the combination of olaparib with bevacizumab as maintenance regimen in patients with advanced high-grade HRD positive epithelial ovarian cancer who responded to first-line treatment with platinum and bevacizumab. And I'm going to go into all these statements in a little bit more detail to expand the information. So first, we're going to start by comparing some study designs between SOLO-1 and PRIMA. And again, this will help inform you on selection of medications. Both studies were international randomized double-blind studies. SOLO compared olaparib to placebo, PRIMA compared niraparib to placebo, and the doses are as listed there. For SOLO-1, the eligibility criteria was that the patient must have a BRCA1 mutated tumor or germline mutation with no prior bevacizumab, had to be stage 3 or 4, and had to have a complete or partial response to platinum-based chemotherapy. For PRIMA, the criteria was stage 3 inoperable or residual disease, or stage 4, and again, complete or partial response to platinum-based chemotherapy. There was significantly higher number of stage 4 disease in PRIMA, just based on eligibility criteria. That made sense. And there was a higher rate of neoadjuvant chemotherapy use and interval debulking compared to SOLO-1, which had more primary debulkings. You can see there the rate of no evidence of disease or complete response after platinum chemotherapy. And obviously in SOLO-1, 100% were BRCA mutated, whereas in PRIMA, only 30% were BRCA mutated. In PRIMA, the Myriad MyChoice HRD testing was used, and the primary endpoint for both was progression-free survival. You can see here the SOLO-1 results for 5-year progression-free survival. And as you can see, the curves do diverge, and the olaparib arm had a significantly better progression-free survival, with a median progression-free survival of 56 months compared to the placebo arm of 13.8 months. PRIMA also had a improved progression-free survival. They broke it down by BRCA mutated HRD patients and HRP, and all three groups had a benefit. And you can see the median progression-free survival on the right side for the BRCA mutated status was 22 versus 11 months. HRD status was 19.6 versus 8.2 months. And the HRP, again, did show a benefit in progression-free survival and was significant, but the difference was only 3 months. Comparing select adverse events, you can see the rates of any grade toxicity and grade 3 toxicities for both olaparib and placebo in SOLO-1 and niraparib and placebo in PRIMA. Of note that in PRIMA, niraparib had higher rates of anemia, thrombocytopenia, and neutropenia, as well as insomnia and hypertension, whereas olaparib seemed to have higher rates of nausea, vomiting, diarrhea, and fatigue. Again, based on these side effect profiles, this should help guide selection of medication. So first-line maintenance for BRCA mutated patients, both olaparib and niraparib included BRCA patients. We obviously cannot compare these across trials. PARP preferred for first-line based on improved progression-free survival and lower MDS and AML with first-line treatment when compared to second-line maintenance treatment. And we're getting more and more data suggesting that first-line truly is the better time to be using maintenance PARP inhibitors. So again, PARP selection should be based on discussion with the patient to review side effects, tolerability, drug dosing schedule, and the expected duration of therapy. Of note, and I'll get back into this a bit later, but in the first-line setting, the olaparib duration of therapy was 3 years, and the niraparib duration of therapy was, the olaparib duration of therapy was 2 years, and the niraparib duration of therapy was 3 years. So in the BRCA wild type epithelial ovarian cancer, only niraparib is approved. All BRCA wild type patients who have responded to first-line platinum-based chemotherapy should be considered for niraparib. If HRD testing is available, we know there's a lower magnitude of benefit for HRP patients, and that testing should help guide and inform the patients. Other options would be observation, participation in clinical trial, and maintenance therapy with bevacizumab. So quickly reviewing bevacizumab, we'll review ICON-7 and PAOLA-1. So ICON-7 was published in 2015. As many of you know, it enrolled just over 1,500 patients with advanced or high-risk epithelial ovarian cancer. They're randomized 1-to-1 with standard chemotherapy, which at the time was IV carbotaxol Q21 days, or standard chemotherapy with bevacizumab at 7.5 milligrams per kilogram. And then they did, after the 6 cycles of chemo, 12 3-week cycles of maintenance bevacizumab. PAOLA-1 had 800 patients. They were randomized 2-to-1, and they received, after chemotherapy, 15 3-weekly cycles of bevacizumab with 15 milligrams per kilogram, and olaparib, or the same bevacizumab, and placebo. So the ICON-7 survival results are shown here. They found that Bev plus standard chemotherapy, followed by Bev maintenance, led to improvement in progression-free and overall survival. You can see the progression-free survival benefit was 16 versus 10.5 months, which was statistically significant. And in the high-risk patients, the suboptimal debulked stage 3 and stage 4 patients, there was an overall survival benefit seen as well. PAOLA-1 looked at progression-free survival by HRD status, and they found that in HRD positive patients, the olaparib combined with bevacizumab was better for progression-free survival than placebo and bevacizumab alone. So where does PARP inhibitor and bevacizumab maintenance fit? Well, if we were looking at the ideal situation, this was the outline that we felt was appropriate. So if you have platinum-based chemotherapy without bevacizumab in your first-line therapy, and you're BRCA mutated, for maintenance therapy, the recommendation would be either olaparib or niraparib. In the BRCA wild type, with HRD testing, and you are found to be HRD, the recommendation would be for niraparib, and for and if you do the HRD testing and found to be HR proficient, niraparib is approved in this group with the caveat of discussion and patient-informed consent. If the patient received platinum-based chemotherapy and bevacizumab in the first-line therapy and they're mutated, the recommendation of the group would be to continue with maintenance with olaparib and bevacizumab. This would be true in the HRD patient population as well. In the HR proficient patient, the recommendation would be to continue with bevacizumab maintenance alone. Now, there's some caveats to the payola regimen. For patients with HRD, maintenance therapy with bevacizumab plus olaparib, followed by chemotherapy and bevacizumab, remains an effective evidence-based approach. However, bevacizumab use in first-line setting is not consistent across all provinces, and not all provinces have access to bevacizumab in the first-line setting. The other caveat is that Health Canada approved bevacizumab at a dose of 7.5 milligrams per kilogram, as per the ICON 7 study, but the payola study used 15 milligrams per kilogram, which was reflective of the Berger study, the GOG study for bevacizumab. And so the dosing is not quite the same as what is approved in Health Canada. Again, the payola 1 regimen is not approved by Health Canada and currently not reimbursed by any province. So although our consensus is to recommend this, we do realize that it's not reimbursed or funded by any province at the moment. And again, access to HRD testing is limited. And so therefore, finding out if a patient is HRD or HRP remains a challenge in our country. So our final consensus statement is looking at dosing and duration of PARP inhibitor maintenance therapy. I alluded to this a little bit early on, but we're going to go through this in a little more detail now. So olaparib should be given orally at a starting dose of 300 milligrams twice daily for 2 years in patients that respond to first-line maintenance therapy. Treatment can continue beyond 2 years in patients that have evidence of disease and the treatment has been felt to be beneficial. So if they're still responding and still benefiting from the treatment, you may continue past 2 years. And this is in line with the SOLO-1 data. Niraparib should be given orally at a starting dose of 200 milligrams for patients under 77 kilograms and platelets less than 150, or 300 milligrams for patients that are over 77 kilograms with a platelet count of over 150. Again, this was approved for 3 years, and it can be considered to proceed past 3 years in patients who have had response or an ongoing benefit to treatment. The group also wanted to highlight that it's very important to inform the patient right away of the expected treatment duration in order to avoid confusion and the patient essentially being upset at the end of either 2 or 3 years because their expectation was to continue for a longer time frame. Looking at the SOLO-1 data with regards to dose modification and dose interruptions, you can see that there's certainly more dose reductions and interruptions compared to placebo, but 47% of patients in the trial completed olaparib at 2 years, 10% continued olaparib beyond 2 years, and 57% continuing or completing olaparib greater than 2 years. And an interesting point is 64% of patients actually continued on the starting dose of the olaparib, the 300 milligrams BID, at or greater than 2 years. Common reasons that dose reductions were needed were for side effects, anemia, fatigue, nausea, neutropenia, or bowel effects. Most resolved with supportive care. For the NOVA trial, niraparib versus placebo, they looked at grade 3 and 4 thrombocytopenia, and the initial study showed that patients under 77 kilograms or a low initial platelet count were at higher risk of having grade 3 thrombocytopenia with niraparib. And a post-hoc analysis found that a reduction of the dose of niraparib to 200 or 100 did not impact the progression-free survival, but actually did improve tolerability of the medications. And so if you look at the PRIMA results with dose modifications, you can see that this first column is the fixed dose of 300 milligrams once a day. Second column is the individualized dosing of 200 and 300. And you can see that the rate of dose reductions, dose interruptions, and grade 3 and 4 toxicities all decreased with individualized dosing. And therefore, that is why the dosing recommendations had changed from the initial fixed dose to individualized dosing. There remains no evidence in the literature to continue the PARP inhibitor past the recommended timeline of 2 to 3 years. And it's really important to discuss the planned duration of PARP inhibitor maintenance at the treatment initiation. Data currently supports a duration of maintenance therapy. And in SOLO-1, there's no change in the rate of disease progression at 2 years when this was looked at. And there have been no trials actually evaluating extending PARP inhibitors beyond 2 to 3 years. And the balance is, would there be improved survival outcome, or would that increase the risk of toxicity or secondary malignancy? And unfortunately, this question is currently not answered. So the consensus statement is that routine clinical assessments and laboratory monitoring are required for the duration of therapy, taking into account common adverse events. Toxicities can be managed through dose interruptions, reductions, and potentially you can re-challenge. Switching between approved PARPs in the first-line maintenance setting for unmanageable toxicities is a reasonable option with the goal of continuing PARP inhibitor therapy. So the suggested follow-up and blood work schedule for PARP inhibitors are that we'll start with visits. Visits should be monthly for the first 6 months, and then every 1 to 4 months based on symptoms and clinical features for the next 6 months, and then every 2 to 4 months after that. For blood work, the recommendation is for a CBC weekly for the first month for niraparib, and then every month until 2 years, and for olaparib every month for the first 2 years. After the 2-year time frame, every 3 to 4 months or at routine visits. Blood pressure should be regularly monitored at home, and the patient should review the blood pressure results with the physician that may have to start antihypertensives or adjust medications as needed. And as mentioned in the previous trials, grade 3 or above hypertensive events were reported in 6 to 8% of patients. In order to manage non-hematologic toxicities, if it's greater 1 or 2, the consensus was to continue with treatment. Consider dose reductions or interruptions if symptoms don't improve and based on clinical tolerability and patient preference. If there is grade 3 or greater toxicity or prophylaxis is not feasible, withhold for a maximum of 28 days until resolution of the adverse reaction, and then consider starting again at a reduced dose. And if grade 3 or higher toxicity lasts for over 28 days at the lowest dose, then discontinue the medications. If there's a specific unmanageable toxicity that is more common in one PARP inhibitor than the other, switching to a different PARP inhibitor has been deemed acceptable by the Canadian Agency for Drug and Technologies in Health, CADTH, and the recommendation of this consensus statement as well. So in summary, the consensus statement state the following: that BRCA1 and 2 mutation testing should be done in all patients with advanced stage epithelial ovarian cancer. HRD assessment should be done, and both are needed to guide PARP maintenance therapy following response to first-line chemotherapy. PARP inhibitor maintenance demonstrates substantial progression-free survival in BRCA1 mutated patients, with 50% of patients on SOLO-1 being recurrence-free at a median follow-up of 5 years. Although HRD assays are currently imperfect, they can certainly give more information to patients and help inform decision. Optimization of HRD tests will help understand resistance to PARP inhibitors and improve therapies for patients. And recommendations for PARP inhibitor maintenance may change as more survival data matures and we get more information on duration, as well as details on further testing, like the role of HRR gene mutations. And finally, new therapeutic strategies for first-line advanced epithelial cancers continue to be investigated. For example, PARP inhibitors with immune checkpoint inhibitors, and if adopted into the Canadian treatment landscape, will require a guideline on the selection of use of PARP inhibitors in epithelial cancers, and will require an update on the consensus statement. Thank you for your time and attention, and I hope that you found this useful.